You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast, and I have Dr. Kim Kush of CariFree, CariFree.com, and a carie, which is, dentist parlance for a cavity. Regular folks probably call them cavities, but for some reason dentists call them caries, which actually would probably be my first question. But Dr. Kush, thanks for coming. How you doing?
I'm doing great, Rich. It's great to be here with you today.
Yeah, why do they call cavities caries? Where does that come from?
Well, it's actually a Latin word. If you think of carrion, which is rotting, flesh, like on roadkill. So caries is that, basically is a term for rot. So basically it was kind of a Latin description of a tooth rot. And, we use Latin a lot in medicine and dentistry. And so, it's just something that carried over. But most people don't, dentists talk about dental caries, but most people talk about cavities. They're just tooth decay, which is, I think easier for people to understand. But that's where the word comes from.
Oh, yeah. I don't know if I should have asked. It sounds horrible, like carrion or something rotting.
It's not a particularly attractive description of a cavity, no. But it's actually pretty accurate because, the inside of the tooth is made up of a lot of protein, and essentially these bacteria that get inside of your tooth and create the cavity or actually digest and break down and rot the protein that's inside of there. So it's accurate, it's not a pleasant thought.
That's what I wanted to ask you. So what, I know, you wouldn't be into this so deeply if there wasn't more to it. So what do, folks that aren't dentists think happens to cause cavities in their mouth? And then what do your run-of-the-mill dentists think cavities are and how to treat them? And then I want to go into what you've observed to be true, which may be very different.
Yeah. I think that's that's the biggest challenge. And for me, I've been practicing 40 years. It's really hard to imagine that. But,
wow.
I've been in the same practice in my hometown that I grew up in since 1982. And, over a span, so I've been in Albany for 37 years. Over the span of 37 years, I see patients that I'm looking at their grandchildren that are coming in to see me now. And these people have been with me for the entire time, and you get to know them really well. They become family to you, right? So about 20 years into this process, and so you care for these people. That's what I do every day, right? I go to work because I care about people. And after about 20 years of practice, I was like, all the things I was taught in dental school about drilling and filling cavities and stuff, at some point in time, if everything that I was taught worked, my patients should stop getting cavities, right? Like if all this education knowledge, because I told them what to do, I told them what I'd been instructed, I shared that with them, I tried to help them, and yet they continue to get cavities. And, it took me about 20 years to get really frustrated with the thought of I'm not really helping these people, right? If I can't help get them decay free, what's my goal? What's my role here, right? If I can't do that, what am I doing here? And I think the biggest confusion for patients is they go to see their dentist and they have no idea. They walk in and sit down for their checkup and they don't know if they have cavities or not. cavities in the early stages are asymptomatic. So, they come in and sit down and go, well, do you have any, you have any cavities today? Well, how would they know? They don't even know what causes cavities, and they don't know if they have any or not. And we have this concept that it's a matter of neglect, like, well, you didn't take care of your teeth. And I tell you, if it was all about floss and fluoride, I wouldn't have a job. I mean, if it was simple as that, I'd be out of work. But the answer isn't that simple. It's a really complex disease. And so dentists, I think, again, the majority of our education time is spent on learning how to fix and repair the damages from the disease. And I think the thing that bothered me the most was 20 years into it, I felt like I don't even understand this disease that I spend most of my time treating. Like I really felt like I didn't.
Interesting.
I had a background in microbiology. I'd been taught all of these pathways, but I didn't really feel like I really understood, because if I really understood the disease, then what I'd been trained should work, and it didn't. So I thought, something was wrong here. And I think your average dentist, we know we're really good at repairing the damage from dental caries or from tooth decay, but on average, we really don't have a great handle on what causes those cavities in the first place. Our education is more focused on how to restore the teeth, rather than how many cavities you have and how am I going to fix them, rather than asking the real basic question, which is where we should really be starting from, which is, why do you have cavities, right? Why do you have cavities in the first place? And let's figure that out and then fix that. And, so that was the approach that I got involved about 20 years ago, was looking at, okay, so let's figure out why this patient has cavities, and let's address and mitigate those risks, and then they should become decay-free, at least get on a road toward health. And so that really changed my entire mindset. But it's really, I think, the biggest challenge for us as dentists is to step away from the restorative model and look at the medical model of, like, okay, let's treat this like a disease proper, and let's figure out what the cause of the disease is and fix that instead. And so, that's what really motivated me 20 years ago. And I think that, the average patient doesn't understand what causes cavities, and quite frankly, the average dentist doesn't understand well enough yet. Although that's changing, it's changing pretty well in the last 20 years.
Okay. Yeah, I mean, like, one phenomenon I've experienced, and I know you've seen it, like, I'm lucky with teeth. My wife hates it because she's had a lot of teeth problems. I brush my teeth every day. I just do it like once a day. If it grosses anyone out, sorry. But I've had one cavity in my life when I was 14, and I didn't even know if there was a cavity. And I'm over 40, and I go to the dentist, but like, they're like, oh, okay, they just clean you, and I'm fine. And other people, like, they're constantly having problems. So there's a vast difference. Where do you think that difference comes from? Have you observed it, first of all? I'm sure you have. And where did the difference come from, you think?
Yeah. So, there's been a lot of research done on, asking that exact question, like, why does this person not have any cavities, and why does this other person have cavities, like, every time they go to see the dentist, right? Why is it just a continuing problem for them? And probably John Featherstone at UCSF has done the most research on that. And we've identified basic risk factors now that we know that contribute to your risk for getting cavities. And they've been validated in large clinical trials looking at, over 12,000 people. And I've done the same thing on my own, looking at patients clinically and looking at those risk factors and, the incidence of those risk factors in patient population in private practice. And the number one risk factor is dry mouth. At this point in time, in the data that we have, 63% of the patients self-report that they experience a dry mouth at some time of the day or night. So I've one of the things I've tried to do in the last 20 years is when I first got involved in this caries risk assessment model, it was very complicated, and quite frankly, it was confusing. It was confusing to dentists and hygienists. It was confusing to patients, and so I spent the last 18 years trying to simplify it. And one of the things I've identified in my own practice is I see basically four main risk factors and I think expressions of this disease. And if you can just kind of start to look for those risk factors, that kind of like appearance of the disease, you can target immediately what you think the patient's problem is, and then target your questions to, like, ask them about those risk factors. But the number one was dry mouth. And I think you see a lot of information, that a lot of advertisements on television with products And the reason for that is because a lot of people are experiencing that issue. Our saliva output is about 2 liters per day, but as we age, that slows down. And then if you take medications, the number one side effect of any prescription medication, I mean, almost all prescription medications, is dry mouth. It reduces the amount of saliva you have. So we've got, 70% of all Americans across every age demographic. This is 70% of all Americans take at least one prescription drug per day. 50% take 2 or more, and 20% take 5 or more. Right. So as you get older, your saliva decreases naturally because of your aging process. And then you start taking more medications, and suddenly you have this really dry mouth. Well, why is that important, right? Why does that create a risk for tooth decay? I mean, that's an important question to understand. And that work goes back to the late 1980s with Philip Marsh from the UK. And Dr. Marsh, in his research with using a biofilm model, demonstrated that it wasn't the sugar availability that changed the biofilm in the mouth on the teeth, but it was actually the pH. And so saliva is neutral, and or the stimulated saliva when you start to eat is actually quite alkaline. And so it's your body's way of protecting your teeth is to bathe them constantly in this alkaline environment that's super saturated with the minerals that the teeth are made out of. So, we have these, it's an amazing system, but we have these hyper mineralized structures in our mouth, which we call teeth, which are only exist because they're continuously bathed basically 24 hours, 7 days a week in this super saturated solution that's alkaline that protects them. Enamel starts to dissolve, pH of 7 is neutral. You have a background in chemistry, at 5.5, enamel starts to dissolve. Well, the bacteria that feed on anything you eat that are on your teeth, and you have a biofilm on your teeth, and we all do. We have biofilms throughout our entire bodies, but we have biofilms on the teeth. And if you have a healthy biofilm, your teeth stay in balance. But every time you eat, the pH in your mouth drops. And some of the bacteria actually function to raise the pH back up, but your saliva is the major protective factor for your teeth. So if you reduce the amount of saliva you have quite dramatically, suddenly the protective mechanism is gone. And then the bacteria that produce the acid that like an acidic environment, they take over the biofilm, and now you've got a biofilm that's totally dysfunctional. And, you watch the teeth just break down at that point in time. So that's the number one risk factor.
Yeah, so I'm thinking people that drink a lot of coffee and not enough water have heard coffee is acidic. So I would bet that they're changing their pH consistently and keeping it more acidic. People that drink soda, I mean, that's really acidic. I don't even know what it does to drink a soda in your mouth. I mean, it must be a real shock to the bacteria there.
They're carbonated with carbonic acid, and so the pH of sodas and coffee is somewhere around 3.5, and that enamel starts to dissolve at 5.5, right? So you've got 100 times the acidity that it takes to start to dissolve enamel, when you drink coffee or tea or wine or anything pretty much. Water, you got to be careful with water, however, because I was for years telling my patients, if you can't do anything else, just rinse your mouth after you eat, just rinse your mouth out with water. Well, the problem is half of the bottled waters on the market, about half, have a pH of 4.0. They're about like sodas, and they're actually manufactured by the soda companies. And the way that they get shelf life stability, they take, the chlorine stuff out of this water, so you have really pure water. The problem is it's not shelf life stable, and so they acidify, for stability. And so they have a pH of 4.0, and continue to be all day long.
The pH is that low?
Yeah, I know. It's shocking. Yeah, I had
and
no
you can't.
either.
I mean, you can't taste it, can you? Or are we just used to the taste of acidified water?
You absolutely can't taste it. So you can go look that up you can Google search that and look for pH of bottled waters and look at different brands and the pHs of them. So that's something that now I tell patients, if you can't do anything else, rinse your mouth out with tap water, because tap water should be about 7.15 in most communities, somewhere in that neighborhood. So, that's a safer approach. That's more neutral. But that pH really alters the biofilm content and the behavior of the bacteria. Even what we used to think were the good bacteria even start to produce acid and kind of join in the party at some point in time. So it's really an environmental issue with the biofilm and the acid produced. So that medication, I mean, it's not surprising then that 70% of our patients are taking at least one prescription drug every day, and 63% of them self-reported dry mouth. So that's like the number one risk factor in my mind for all the tooth decay that we're seeing today. Number two is diet, and 55% of the patients in my studies self-report they either eat too many times during the day, they eat too frequently, or they eat too much sugar. And if the American diet, I mean, the average American eats 23 teaspoons of sugar per day. Now, I would encourage your listeners to go to their kitchen, get out a measuring teaspoon, and measure out 23 teaspoons of sugar, and look at how much that is, because it's shocking. But if you look at how much sugar is in a can of soda, a 12-ounce can of soda, or you look at what hidden sugars are in so many of our processed foods, that the average American, it's one of the reasons that we have the diabetes epidemic, obesity, hypertension, heart disease, cancer. I mean, you go back to sugar, and we're off the chart on sugar here in the U.S. and it's shocking. And so sugar is a big issue, because those bacteria easily break that sugar down the mouth, and it produces acid. You produce the acid, it drops the pH. Suddenly, the teeth they can start to dissolve a hole in the tooth. You don't have enough saliva to protect yourself. Suddenly, you got a recipe for disaster, right?
The other problem, couple quick questions in here before we move on.
Yeah.
There's a lot in here.
Yeah.
So that tells me if you don't take breaks between your eating and you eat very frequently, you're constantly recreating that acidic environment in your mouth. And even with normal saliva, you just don't have enough time for it to sit in the basic state. So you're stressing the bacteria in the mouth by eating too frequently.
Yep. Rich, you are right on. The term we use is the phrase is gulp, don't sip. Like I tell my patients, you want to have a soda, have it with a meal and drink it all at one time. I mean, you don't have to chug it, but have it with your meal and get it over with. Where people run into problems is like they'll sit at work and they'll put creamer or sugar in their coffee, and then they'll sip on it like for 4 hours. And so what you're constantly doing is dropping that pH in the mouth for a 4-hour period of time, and that changes the biofilm. And so it's whether, eating too frequently is as important as eating too much sugar. And so you take a healthy mouth that has enough saliva and you eat, and the pH in your mouth drops, and it takes about 15 to 30 minutes for that mouth to recover. And when that happens, as the pH drops, actually nanoparticles of the mineral actually come out of the tooth. They dissolve and they get trapped in the biofilm, and then as the pH raises, they go right back in. So you have this equilibrium going on, this dynamic where the surface of the enamel is dissolving and remineralizing every time you eat. And in a healthy mouth, you have this equilibrium and this balance. It's when you get out of balance that then you have a net loss of mineral from the enamel, and then you're starting to get into the decay issue. So just eating too frequently or sipping too frequently on anything like that is a challenge as well. So those are the two biggest risk factors.
I got a quick question too.
Yeah.
That's all right. You said, so when your mouth's in an acidic environment, the enamel is dissolving and then it's moving around the mouth and remineralizing, or does it somehow stay local to where it dissolves?
It actually gets trapped right by the biofilm on the surface of the enamel, and so it, we have this protective layer of protein that precipitates from the saliva on the surface of the teeth, and the biofilm grows on that, and it actually just gets trapped right there, and it goes right back into the teeth. So it just comes out of the surface, it's kept right in that area, and it goes right back in. Actually, that becomes another thought is if you eat and then immediately go brush your teeth with like an abrasive toothpaste, the whitening toothpaste, which tend to be quite abrasive, and you remove all of that pellicle and the protein layer and the biofilm from the surface of the tooth, you're taking away the mineral, content with it. And so it's actually, we've always been trained to eat and then go brush your teeth. You're actually, if you think about this from a biofilm standpoint, you're better off to brush your teeth first and then go eat, right? So that you're not brushing away that mineral that dissolves, you're trapping that, you're keeping it. So, there's just little things that when you start looking at the biofilm model, it's like you start looking at what our habits and what our old belief system is, and it's like, wow, let's change how we behave. The next biggest risk factor is just the biofilm itself, and people either have the wrong bacteria, and they've had too many acidic exposures, from their diet or from not enough saliva, and you get these acid-loving, acid-producing bacteria that take over the biofilm, or they just have too much biofilm. Period. Like they're not doing an adequate job of brushing and removing the biofilm, and trying to keep
one more. All right, so a couple more questions here. What does mouthwash do to you? What about people that have mouthwash?
So
or use it?
You have to be really careful with the mouthwash. They're a lot like bottled water. A lot of them are very acidic, and it's like in the pH of 4.0. So it's like, yeah, they'll kill the biofilm, but at the same point in time, and they'll reduce the biofilm load, a lot of them, but a lot of them either are alcohol-based, so you have that as an issue, and or they're quite acidic. And the reason for the acid is shelf life stability, typically. But again, so you're trying to get rid of these acid-loving bacteria by rinsing them with acid. Just doesn't make a lot of sense.
The mouthwash, if it's killing the bacteria in your mouth, I mean, it probably doesn't preferentially kill, or maybe it preferentially kills in the wrong way, and the alcohol dries out your mouth, and I mean, who knows what it does? I don't know. It sounds pretty bad, actually.
It's not preferential. So, and that was one of the things that led me to work on the research that I did and the products I created based on Philip Morris's, work in the 80s. Was I thought, well, let's try using some alkaline products and see what happens. Like if his theory is correct, then by helping support the body the way nature does it, by raising the pH, will that make a difference? And will it help change the biofilm to a healthier behaving biofilm or a healthier content? And it appears to do that. In fact, it appears to do that quite well. So that's where I got involved in that research.
Okay, a couple more questions here. Alkaline waters. I've seen those advertised, pH supposedly 8 up to 9. And they do have a different mouthfeel. Are those truly alkaline, or do you feel like they're beneficial?
Yep, I think they're alkaline, and I think you're certainly better off using an alkaline water, drinking it. I don't know what effect the alkaline water has on your overall health, right, and the rest of the body, but at least for the teeth, having a pH water of 8.0 or 9.0 would certainly be more beneficial than having one at 4.0.
Okay, and then I've been thinking also about mouth breathers versus nose breathers. Do you think that mouth breathers expose the mouth cavity to more oxygen, so it prefers aerobic versus anaerobic bacteria, or both even present? I don't know.
It just tends to, patients that are mouth breathers tend to have more problems with dry mouth, particularly at night. When we sleep, our body actually reduces the amount of saliva output. Otherwise, we'd choke on our saliva while we're trying to sleep. So your saliva output lay down while you're asleep. And if you're breathing out of your mouth and you have it open, you dry the mouth out even more. So it just, gives a greater opportunity for the pH to drop. So that's, you just don't have the protection on the teeth at night, from, your alkaline saliva while you're asleep. So that becomes an issue as well. Yeah, and then the last...
go ahead. Sorry. Yeah, I keep asking you more questions, but go ahead with the last one.
Yeah, okay. Yeah, and then the last major risk factor, the last usual suspect is genetics. And there's been a lot of research in the last 9 years on looking at different gene sites, how different genes, and when you were asking the question, why have I never had a cavity, and, why has my wife maybe had all this tooth decay and all these issues her entire life? And so if it's not saliva, it's not a dietary issue, and you're adequately, taking care of the biofilm on your teeth, it could well be genetic. And there's probably 50 genes that have been identified now that appear to play a role in your risk for tooth decay. And although that it's interesting because I got to spend time with who I think is the leading expert in the world, Alex Vieira, and talk to him about specifically about what role genetics plays. And he said, we've analyzed all the data and we know exactly what that is. And I've heard ranges anywhere from 30 to 60%. I mean, it's a guess at this point in time because we really don't have any way to measure that. Alex said, no, we've run all the data for tooth decay. It's 9%. So I go, so it's maybe not.
That doesn't tell you the mechanism or which genes or coding sequences. It doesn't tell you the method of action. No. It doesn't tell you how to stop it. That's crap,
I can't, and the challenge with genetics is you're exactly right. I can't diagnose it accurately. I can't tell you which gene, if you have an issue and it's genetic, I can't even exactly diagnose that for you other than if I ruled everything else out. I'm going to assume that you've probably got a genetic influence, but I don't know which gene is causing that. And I can't change your genome, not yet anyway, right? I can't measure it and I can't change it right at the moment. So it's just something to know that you have a genetic risk. So we have to be really careful about, really mindful about not having a lot of acidic episodes in your mouth, making sure you have a really healthy diet, making sure you're not eating too frequently, making sure that, you're not suffering from dry mouth, trying to keep your mouth adequately adequately wet, during the day, moisturized, and with something that's not acidic when you're trying to do that. So that becomes a challenge. But so you say it's 9%. Well, okay, so that's not a big influence. But for the person who has that problem, it's 100%. Does that make sense?
Right. Exactly.
Right. So it's only 9% on a population basis. But if you look at an individual, if somebody has a genetic problem, it's an extent influence for that person. It might be 100% of the cause of their problem. So, so that's a real issue for some people, or at least let's say for 9% of our patients. And it's hard to identify, and it's hard, and it's a challenge. So the most important part is just to try and be as mindful and healthy as you can about, taking care of the biofilm on your teeth.
Well, there's also adaptation. All creatures adapt. So what are you doing to the bacteria in your mouth, the microbiome in your mouth after years of soda or coffee or whatever? How is your body changing epigenetically? And I know this is out of the scope, but just, you say, your genes. What about your epigenome, epigenetic marks? And they're somehow being altered too by this behavior. So please get out of here,
The environment plays a huge role, right, with your genes, right? And I would say that we really don't understand that very well in the big picture, and certainly we don't understand it very well for tooth decay at this point in time. But that's on the horizon here, and we're starting to talk about epigenetics because the environment does influence the expression of those genes. An analogy I like to use with patients is that I think is kind of simple. It's kind of like your genetics are the ignition switch in your car, and environment is either the gas pedal or the brake, right? So it's the environment has the influence of either accelerating a problem or not. But we're born with the genes that we have, and trying to understand, well, how does that influence it? And certainly spending a lifetime of drinking soda, eating wrong, and not taking care, not brushing, taking care of your biofilm if you're taking a lot of medications, that does change the biofilm in your mouth. It changes the content of the bacteria that are there, and it changes how they behave. More importantly, it changes the pH. So, so I always come back to the end of my usual suspects are saliva, diet, the biofilm, and genetics. But at the end of the day, it's all about pH. So if you can maintain a healthy pH in your mouth, you're not going to get tooth decay, and it's as simple as that. So it's
Tell me about some of the phenomena you've seen over the years, or experiments you've seen that just either mystified you or surprised you, or you thought were really instructive to you. What kind of work is being done out there, or what have you seen that you're like, that's crazy?
So I think the most impactful stuff that I've seen is certainly some of the work that we've done working with elevated pH, just trying to raise the pH in the mouth, trying to protect the teeth. And I did some biofilm research back, like 2005 to 2010, actually taking, biofilm samples from patients and then putting them on alkaline oral healthcare products, and then going back and looking at, did that impact or change the makeup and content of their biofilm? And it did. It only took like a month, and I saw a significant change in the biofilm. So we know that we can influence and drive that. We did a study in Townsville, Australia, in that same period of time on school children, and they were all high risk. They were in a real poverty area, and they were all high risk for tooth decay. They were averaging 2.5 new cavities per child per year. And we put them on an alkaline rinse. And that's all they did. That's the only variable in the study. We just had them rinse at school for 30 seconds once a day, and we reduced their decay. We reduced their decay rate by 73%, and that's off the charts in terms of results. So that's something that I think it's really important that to understand that we can change the the content and makeup of the biofilm. Like I say, if it was all just floss and fluoride, like I was taught in dental school, we wouldn't have a tooth decay problem today. If people would, because we got adequate exposure to fluoride. It's in the water. It's in every product, oral healthcare product practically that you can put your hands on.
Here's a question for you. So if you could only do one of two things, if you could either brush your teeth twice a day, or you couldn't brush your teeth at all, but you would, swish around an alkaline solution in your mouth twice a day for 30 seconds, which would you take and which would have more of an impact?
So I would brush my teeth twice a day with an alkaline gel.
But if you can only do one of the two, which one do you think is more impactful?
Oh, I think actually, that's a really good question, Rich, and I haven't really studied that per se, so I couldn't really give you an answer. But me personally, I would brush twice a day, but I'd want to use an alkaline product, which is what I do.
Yeah, and a toothpaste. Let me guess, they're probably acidic, right?
Yeah, yeah. It's hard. Yeah, I know. I was shocked. I had no idea that oral healthcare products were acidic back in 2001 when I started studying this. I was shocked at how acidic most of them are. You're starting to see some products that are, getting to neutral or, certainly elevating the pH. And this will become more of an issue. And one of the greatest challenges we had was if you create a product and you acidify it, you take it down to a pH of 4, nothing wants to grow in it. You can put it on the shelf for 2 years and nothing wants to grow in it. You raise it to a pH of 8 and everything wants to grow in it. And then the other challenge you've got is that all of the preservatives that we typically use for all of our food, healthcare products or whatever, are most active in an acidic environment. So you get above pH of 8 or so and they don't work anyway. And I mean, they're inactivated. So the greatest challenge, it took us about 4 years to figure out how to stabilize on the shelf any product like a rinse or a gel that was alkaline. Most of the products we created have a pH of 9 or higher. So that was the biggest challenge, and that was I think for me was a surprise, not understanding how acidic a lot of products are. And I mean,
what happens if you make them so basic that they do have a pH of 9.5? Does it have the same antimicrobial or shelf stabilizing effect, or no?
Not really. And so, although we have figured out, and some of that's proprietary, we have figured out how the shelf life stability, but that was a big issue. But given the chance, so I understand why bottled water is acidified. I understand why a lot of our processed foods that are canned are acidified. I mean, I get that now, but I didn't understand that 20 years ago.
Well, what about a product that has an outer coating that is acidic, and even if it goes in the mouth, the coating is quickly dissolved, and then the rest of it is basic, and the bolus of it is big enough or thick enough that it still helps change the pH back?
Yeah, that's an interesting thought, and certainly it sounds like it would work. As long as you just it's okay to have acidic episodes because you can't avoid that because every time you eat that happens. If you don't eat, you die. But you gotta have a healthy environment where your mouth and your teeth can recover and remineralize. And, that takes, like I said, it takes 15 to 30 minutes in a healthy mouth. And somebody that doesn't have enough saliva, that could take an hour or longer. So if you look at it, I think one of the other things that's pretty typical with the change in our American diet, we tend to graze more now. People tend to eat all day long in small amounts rather than sit down at defined meals. When I was a child growing up in the 50s and 60s, you had breakfast, you had lunch, and you had dinner, and that was pretty much it. If you were lucky, you got a snack in the middle of the afternoon, and that is a really healthy way to eat. It's healthier than eating just all day long, nibbling, grazing just slowly all day long, because what you're doing is you're just dropping the pH. You have this prolonged periods of low pH in the mouth, and that's a disaster. So
yeah, I mean, there should be like a after dinner or after meal alkalizer, dessert. It won't be a dessert, but it would act like a dessert for your mouth, and it would stem the low pH environment quickly after eating.
Actually, one of the products I developed is a spray. A mouth spray, and it has a pH of 8.0, and it's minty and sweet, and it raises the pH and it helps boost the pH back in your mouth.
Oh, really?
So yeah. So and
what's it called?
It's called Boost Spray, and it's from Carry Free. It's actually now has a title of CTX2, but it's just a spray, oral spray. And I have a lot of patients use it for dry mouth. Like they'll take it and use it in the middle of the night, like if they're a mouth breather. They'll have a little spray bottle on their nightstand, and if they wake up, they'll take a couple of squirts. I have two really good friends right now going through who are dentists going through oral cancer treatment, and they're using it because they've lost their saliva because of radiation, and it's amazing how much it's helping them. So yeah. Anyway, it's a very complex disease. It's tooth decay is the number one disease in the world. Of all the diseases that the World Health Organization tracks, dental caries is number one.
Well, we haven't talked about the effects of the disease yet. That's the big piece I want to ask you about now. So what I've heard is tooth decay and cavities are like a low grade. I mean, you've heard stories of like I don't know, a deep enough abscess killing someone because it goes into their bloodstream, but just having tooth decay, what does that do? Is that like a low grade infection for your body, or what are the health effects of it? If it's a disease, what does it do?
Let me backtrack just a second, Rich, on that, because this is a really important topic, and I would say we're kind of just at the early stages of that, looking at those bacteria from tooth decay. But I'll give you some statistics and studies that have been done so far. But if we can backtrack for just a second, about 20 years ago, we started identifying that the bacteria that cause gum disease, which is the other major disease we treat in the mouth, those bacteria now are being associated with heart attacks and strokes. One of the bacteria last week, I saw a report, Fusobacterium nucleatum is now associated with a more aggressive or accelerating colon cancer. So we're starting to see these oral bacteria in the other parts of the body do really bad things as well there. Porphyromonas gingivalis, which is one of the probably the most pathogenic bacteria that play a role in gum disease, now we know actually plays a role in heart attacks and strokes. So you start looking at the bacteria, and that information has been around, and that science is developing. So the oral systemic connection between the bacteria in the mouth and other diseases in the body are starting to be more explored and understood. When it comes to dental caries, the number one pathogen for years has been this bacteria called Strep mutans. And when I was in school, we were taught that was the cause of the disease. Man, you have Strep mutans in your mouth, and that causes cavities. It's like a kind of a classic infection. And now we know that that's a really simple model that is not even close to the truth. And I see studies that say, yeah, it's definitely an important player in the disease, and I see other studies that question if what role it plays at all. 40%. Let me give you this statistic: 40% of the people in the United States that have severe tooth decay have zero mutant strep in their mouth. So it's like, okay, so it might play a role in 60%, but in these other 40%, it's not even there. So they've got tooth decay in spite of that bacteria. So, but one of the things that's been studied, because it was such a I think well-considered pathogen for tooth decay, they studied and found it growing on heart valves and coronary arteries in high numbers. When it's found on the mouth, it's found on the plaque in the arteries and the heart valves. It's the number one bacteria found there. We don't know what role it plays, but I always say, if there's smoke, there's fire, right? That's been kind of my experience in life. If the number one bacteria found in a thrombus when somebody has a heart attack, the number one bacteria found in the clot in the blood vessel is Strep viridans. Strep viridans is and that's an anaerobe that is found. We associate that with abscesses, like an abscessed tooth when you have a root canal. So that's like the number one pathogen there. And so then to find that, it's like that's the number one bacteria that's found in the clot in these patients. It's like that. See, okay, maybe it's just a coincidence, right? We don't have a lot of data and a lot of studies yet, but you got to look at that data and go, okay, I don't think it's a coincidence. Things like that in my mind don't represent coincidence. I don't understand what role it plays, but I wouldn't assume it's coincidence. we have well established at this point in time that the strep mutans bacteria that have a CNM gene, they have a specific gene, they actually can penetrate the arterial cell wall, and we know they're responsible and play a significant role now in microbleeds in the brain and strokes. And so, so the next question is, and it hasn't been studied. Actually, I was just reading a paper yesterday. It hasn't been studied yet. They've looked at the bacteria and the incidence of microbleeds and strokes, but the question, they didn't back up and go, okay, well, so did these people have high decay, high tooth decay rates? Like, they didn't correlate the stroke and the microbleed in the brain they correlated to the bacteria, but they didn't correlate the bacteria back to the mouth to see if, they had a high decay rate. So we can't really say, okay, well, if you have a lot of tooth decay, that puts you at risk for microbleeds in the brain and a stroke. We can't say that. If you have high levels of strep mutans, we know that plays a role in the brain. And then there was a study that was published, I think it was last month, that strep mutans also were found at infective levels in patients that had, in biopsies on patients that had dementia and Alzheimer's. So it's kind of like, that and Porphyromonas gingivalis as well. So you start looking at these oral bacteria, and it's like, if you don't have a healthy mouth, I don't think you can have a healthy body if you don't have a healthy mouth, right?
Well, here's something that I was thinking as you were talking. So the mouth, we take in all kinds of things through the mouth, and I mean, the outside world really, a lot of the outside world first comes into contact with us through the mouth. So if your mouth is compromised, if there's a channel through the enamel that goes right to the, that allows stuff to get to the bloodstream. And, let's say you eat something acidic. Now the mouth is acidified. Now something comes into the mouth that's I'll just put a label, bad for you. And it has a direct channel to the bloodstream. Perhaps that's why if you reach a certain tipping point with the mouth and you have enough of these channels or entryways that, you're much more prone to sickness or other problems. I don't know. It's just my guess. But.
And it's just logical, Rich, right? And then if you've got other cofactors, like you've got diabetes or you have obesity or hypertension, you have high blood pressure, and you're just putting yourself at greater. If you don't have a healthy mouth, I think you're putting yourself just at greater risk, as a cofactor for those other diseases. And like I'd say, we don't have a lot of causative studies yet, but I would say we've got enough it's a growing body of evidence that certainly should raise the alarms for us all to be thinking about it.
What about diabetes? Have we seen or has science seen that having just gingivitis or just general tooth decay correlates with diabetes or inflammation or other kinds of conditions?
There's conflicting research out there on that, but I would say that it's certainly. We know that if you have diabetes, it increases that certainly is a cofactor and a co-risk for gum disease. So people that have diabetes, it puts them at greater risk for gum disease. And if they have diabetes, it tends to be more, gum disease tends to be more pronounced or harder to battle in those patients as well. So, there's a lot of research that needs to be done yet on that topic, Rich. And I would say we're just kind of at the start end of that entire field, but it's fascinating, and there's a lot of kind of I would say alarming data that we've seen so far, right? I mean, it should be causing alarm, and I talk to my patients now when particularly patients that have gum disease. I talk to them about the role these bacteria play. We need to be treating this like an infection, and we need to be thinking not just about we're saving your gums and your teeth, but we need to be thinking about what this is doing to your arteries and your brain and, the rest of your body. So that's the conversation.
All right, last question here. Tooth whitening. I got two more. Tooth whitening and braces. What do you think those two things do to your mouth?
Tooth whitening, I think if you're just using one of the gels that are, either commercial or like say the strips or the gels or the trays, something like that, it appears to be pretty safe. I mean, I haven't really seen a lot of those tend to be alkaline as well. So from that standpoint, they're going to help us in terms of the biofilm and the enamel. The whitening toothpaste tend to be quite abrasive, and so I kind of encourage my patients to, if they use them in a very limited, once a week or something like that. But that varies by brand, but that's something that they could look up and, investigate what the abrasivity is of a particular toothpaste if they want to use it. So I would say, the whitening gels and the strips and the trays and all that appear to be pretty safe. I would kind of caution people in terms of using whitening formulated toothpaste just on to check the abrasivity. On braces, I don't know. One of the challenges that we have, particularly if you've got brackets and wires, bonded to the teeth, the biggest challenge we have for kids, that typically it's on kids, teenagers, and teens don't tend to be, a lot of them don't tend to have really great hygiene to begin with, in terms of brushing and flossing. And when you put brackets on the teeth, it collects a lot more biofilm growth. And so that's the biggest challenge for us, is trying to help them keep their teeth clean on a daily basis. And it's a challenge. I had braces. And it's a challenge to keep your teeth clean when you got all that stuff on your teeth.
Sure. Yeah.
So that's the biggest issue. And the biggest challenge, I think, in orthodontics today, is those teeth start to demineralize and they get kind of a chalky white area. It develops around the brackets, and so they end up with these squares on their teeth, which are quite, can be quite disfiguring, from an aesthetic standpoint after the braces come off. That's one of the bigger challenges that orthodontists face, dealing with younger people. Well, people of any age, but typically, adolescents. The trays, they make the clear tray kind of systems to move teeth. I use those a lot in my own practice. They work really well. You just, again, have to be really careful of the biofilm builds up, a lot inside of those trays. So just to keep them clean, when you're using them. But, the clear tray system, the Invisalign type, orthodontics, for minor tooth movement, not major cases typically, but for, your moderate to easy, simple orthodontic cases, those work extremely well. So
okay,
that's it. Yeah. Anyway, so I don't think that it changes anything really. It improves your bite, so it hopefully reduces the wear on your teeth over your lifetime. So it actually is helpful.
So all right, well, very good. I think I've questioned you to death, but it's been a great call. I don't care who says it's nerdy. I think this is so fascinating, this stuff. I'm really into it. So,
Rich, just trying to understand the biofilm and this disease and all the risk factors associated with it, and then starting to look at beyond the mouth. What is this disease having? What kind of impact or effect might it be having in the rest of the body? It's fascinating to me. I've certainly enjoyed studying it, and I think the most grateful thing for me is just being able. I've helped so many patients in the last 20 years become decay free because I asked the question why.
Definitely.
So that's
what are some resources for listeners? Because not everyone, you can't be everyone's dentist, and
right,
some people are local, some not, and some people may go to their own dentist and they may want to say to their dentist, "Hey, check out Carie Free." So what's your recommendation here?
So easiest thing I could do is to go to the Carie Free website. There's a lot of resources on there. There's a lot of videos on YouTube, about caries risk assessment. But we've got a huge resource on our website, cariefree.com, CARIFREE.com, and they could go there and look at all the videos and all the research and data, and they could call the company if they have questions. We have, people call the company direct all the time, and I've got four individuals there that train offices, dentists and hygienists, and I'm out lecturing. I speak at about 8 or 10, major dental meetings per year. So if they're professional, I'd welcome them to come to one of my lectures, and I'd try and help them however I can. I'd like to see this disease. I'd like to see this disease become a piece of history. So anyway.
Okay. Well, very good. Well, I appreciate you coming on the podcast. It's been a really great call.
Yeah. Oh, it's great. It was great talking to you, Rich. So have a great day.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.